Hi, thank you for having me here today. My name is Dr. Wendy Ada. I'm a clinical psychologist licensed in the state of New Jersey, and I work for the Rowan Virtua Integrated Special Needs Center through Rowan Medicine. And today, what I want to talk to you about is mental health, specifically mental wellness, and how we can foster resilience through the transition period. I work for the Rowan Integrated Special Needs Center, and just a little bit about what we do. We are a primary care practice in Southern New Jersey, and we treat individuals usually through the transition ages when we like to bring people in because we know that there's really a significant need for transition services. Oftentimes, individuals are coming from their tertiary care centers, the CHOPs, the DuPonts, the Nemours, and then they come to us, and all of a sudden they need kind of like a safety net, someplace that they can land where they can move from the pediatric system of care into the adult medical care system, and all of their specialists that they've had as children, now they need to kind of look for the coordinate of that in the adult world. And so we kind of help to catch them with that through primary care, providing a medical home and integrated behavioral health services. So we have social work, we have psychiatric care, as well as counseling care here too. My disclosure is that I have no conflicts of interest, not getting anything, not financially benefiting at all from this presentation. So here are the key takeaways, the things that I'm hoping that you're going to learn today. First, I'd like to give you some information about the prevalence of mental health issues for people with IDD. And you'll notice that I use the terms IDD and ID interchangeably. Sometimes I'm saying your loved ones, sometimes I'm saying children, sometimes students, but I'm kind of talking about the same group of people. So we're going to learn about the incidence of mental health for both children and in the adult system of care for mental health problems, what those barriers to care are in the adult world, and then specifically what the barriers to care might be with the transition period, how trauma affects individuals with disabilities, the importance of mental health wellness, both for the individual and for their caregivers. And I'm hoping to give you some tools to foster resilience during this time of transition. Transition is difficult. Change can be very difficult. It can feel a little scary for both your loved one as well as for the parents. So I'd like to be able to give you some resources to be able to foster resilience during this. So just a little bit about the prevalence of IDD in general. Approximately 1 in 6 youth between the ages of 3 and 17 in the United States have an intellectual or developmental disabilities. They typically start before the age of 18 and are considered to be lifelong, and it can affect thinking, learning, motor skills, behavior, social skills, and the ability to have adaptive functionings like, caring for themselves, ADLs, communication. IDD youth are particularly more vulnerable to behavioral, social, or emotional challenges, and they typically have a higher incidence of both mental health and medical disorders. And then youth with IDD are also at risk for traumatic experiences in home, in the community, and sometimes in conjunction with frequent healthcare visits, with pain, with separation from loved ones when they have to go into the hospital. Overall, and this is just from the Center for Disease, this is just overall kind of what the prevalence of mental health difficulties are for neurotypical children. So ADHD and anxiety problems, behavior problems, and depression are the most commonly diagnosed mental health disorders in children. Most of them are occurring together, especially when we're talking about children with IDD. So whereas neurotypical children might have a co-diagnosis of both depression and anxiety at a high rate, when here we're looking at about 74%. When we're looking at children with IDD, we're seeing that it's not just two diagnoses, but oftentimes multiple diagnoses together. Mental, behavioral, and developmental disorders start in early childhood. And between the ages of 2 and 8, about 17% have already a diagnosis. Depression and anxiety over time have increased, and we're seeing even more of an increase. This data is from a couple of years ago, from pre-COVID time. We're noticing that these rates are actually much higher since COVID because of the trauma of COVID and the lack of socialization, the lack of continuity of care. And then the rate of co-occurring mental disorders in youth with IDD is between 30 and 50%. When looking at overall prevalence of mental health issues in children with IDD, there was one international study that kind of looked at a multi-level study to see kind of where we're seeing this across the country or across the world. So what they found was that coexisting mental disorders are common and they persist across the lifespan. Only 1 in 10 children are receiving specialized mental health services when they have IDD. Co-occurring mental disorders are more predictive of major restrictions in pretty much all areas of the individual's life, in their work, in their social participation, in inclusion. And the higher the level of severity of ID, the higher the level or more diagnoses we're finding with mental health issues. The onset of psychopathology coincides with the transition age for a lot of individuals. We see them come in around the adolescence period when we've got hormonal changes coming on, plus the big transition from school and into the work world. And 75% of all psychiatric disorders in adults start before the age of 24, and about 50% start before 14 years of age. So when we're talking about lifelong conditions and the need for that transition of care, these disorders are starting young and they are continuing into the adult world. So transition is especially important. When we're looking at the prevalence of mental health issues in adults with IDD, some estimates are up to 70% have co-occurring diagnoses. About 10 to 20% have challenging behaviors, and we would consider self-injury, aggression, destructive behavior as being a challenging behavior. And 45% of those individuals need some support for self-injury in particular. Psychiatric disorders are 3 to 4 times higher in individuals with IDD than their neurotypical counterparts. And individuals with ID are 6 times more likely than their peers to develop a mental health disorder. And again, as we found with children, with adults as well, the severity of ID is related to the severity of the psychiatric diagnoses. Also, not only are we looking at psychiatric or mental health diagnoses, but just overall levels of distress are higher in individuals with ID. In 2018, about 33% of adults experienced frequent mental distress, which was about half of the month they reported having bad days or mentally unhealthy days due to stress. And we know that high levels of stress are related to physical outcomes, right? Poor health, chronic disease, heart disease, and the need of extra services and supports need to be available for these individuals. And again, these statistics are prior to COVID. So we definitely know that this particular group of individuals, individuals with ID were disproportionately affected by COVID. Our adults lost not only their ability to be able to go to day program or go to work for a longer period of time, even now, and we're talking 2023, there are some individuals that I'm seeing who still are not back to their old jobs or their day programs full-time the way that they used to be. Same thing goes with kids. Children had to transition from being in the classroom to remote learning. And many individuals do not do well with sustained attention, looking at a computer, kind of like you're watching me today. It's hard for them to pay attention. There's a higher level of impulsivity and disattention in individuals with ID. So to try to take that shift over to remote learning was very difficult, and they lost their social supports and their continuity of care and learning, and just kind of knowing how to predict what's going to happen next. Having a routine was very significantly disrupted and led to increased levels of mental distress, and I think we're even seeing in this research. Mood dysregulation is one of the most common difficulties that we see in individuals, adults, and children with ID, and is something that's very treatable. So what mood dysregulation is like chronic irritability, having trouble with mood swings, kind of struggling with those things. About a third of adults with ID have emotional dysregulation difficulties. You add in autism on top of that, and that gets exacerbated because of the hypersensitivity to sensory stimulation, difficulty with cognitive flexibility, as well as potential communication difficulties. So that kind of level of irritability, and that may result in challenging behaviors or mood difficulties, is actually much higher. And being able to target this in interventions for mental wellness and mental health treatment is very important, because this is one thing that we can teach very specific skills to work on. So people with intellectual disability have the same rights as all individuals for not only their physical health treatment, and if you're going to be taking part in the talk with my counterpart, Dr. Jennifer Lecomte, who works with me at the Risen Center. She'll be talking to you today about inclusivity and, some of the barriers to medical care and some of the ways that our patient population are disproportionately not included or receive less inclusive care. So for the same reasons that she's going to be talking about, mental health is again one of those areas where we see that individuals with disabilities are not getting the same level of care. So they should receive the same range and quality of free or affordable mental health care, mental health services which are accessible, services provided in close proximity to where they live, though the advent of telemedicine has helped us to get to more remote or rural areas, or even if there's a challenging day where somebody's having a hard time being able to tolerate, for example, a car ride to come in, we can use telemedicine for that as well. Being able to have mental health professionals who provide a high quality of mental health care and have ethical principles that they uphold, and make sure that we don't deny mental health care to individuals just because of their disability, or because that the clinician feels as though they can't necessarily treat them. We'll talk a little bit about some of the barriers to accessing good mental health care. And one of those barriers is lack of training or comfort level for individuals who are working within this field to work with people with disabilities. So again, here are some barriers to accessing mental health care. So some barriers are factors which complicate assessment. So a good assessment is going to lead to a good diagnosis, which is going to lead to a good treatment plan. However, when we're talking about individuals with intellectual disabilities, oftentimes we don't have good assessment instruments to be able to really get a sense of, their level of depression or anxiety or stress or behavioral challenges. We don't have, qualified people who are able to do those assessments as well. I know, and you've probably had this experience, when you come into your primary care doctor's office, typically they ask you to fill out a questionnaire. It's called the PHQ-9. And basically, it asks you some questions as a screening measure for depression. Similarly, there's one for anxiety as well that's used often in primary care practices, which is sometimes the first place that we're able to really see that there are mental health challenges for somebody. Those two screening measures are often hard to understand for people with disabilities, or they don't necessarily fully capture the the challenges that they're having in the way that they need to be able to tell us about them. So those types of assessments aren't real good. There can be a lack of awareness of symptoms on both the individual's part or their caregiver's part. So, just not really knowing what to look for when somebody's having a mental health challenge, especially if they don't use words to communicate. I think that tends to be one of the hardest, and probably the people who don't get the services that they need or don't get in to see people quickly is because we don't know what's going on. They're unable to tell us, and if they do not communicate verbally, then we're having to extrapolate from their behavior what might be going on, and we have to rule out all kinds of other, perhaps physical, difficulties that might be leading to some of the behavioral challenges. There's some stigma and exclusion from services. We find that in the adult world, people with severe mental health illnesses very quickly get referred to somebody when they need to be getting help, or from the child level into the adult level. When you have an intellectual disability, oftentimes people are not referred at the same rate. There's limited practical support to access services, not knowing where to go, getting this big list from your insurance company, not knowing who, and then you start calling and they say, no, I don't know how to work with somebody with autism. And, that really is a barrier. Inadequate training and awareness for mental health professionals. I can tell you, and I'm not going to date myself, but I can tell you that in my education, I did not get any training on how I might accommodate my psychotherapy to work with somebody with an intellectual disability. And I don't even know that I learned a whole lot about even autism as a diagnosis. So definitely it was not something that was taught. It was something that I had to learn on my own. However, there are very simple ways of being able to modify psychotherapy and to be able to provide the services, and we see that people benefit from receiving psychotherapy with an intellectual disability. But people don't necessarily know how to do that, or they don't want to take the time to really learn how to do that. So we don't have very specific mental health services for individuals with ID. There's a lack of coordination between agencies, and we see this so much in the adult world that we don't have necessarily in the child world. So in the child world, you might be getting your care from CHOP, and you have all of your specialists all under one roof, and everybody talks to each other, and they all kind of work together on a treatment plan. Then you move into the adult world, and we get all of these silos. And mental health is very, very, I think, probably one of the most siloed areas of treatment because of confidentiality. We tend to treat only what we're seeing. We don't look at the big picture. And if you don't have coordinated care, oftentimes you can be treating something thinking it is a variant of a mental health or a psychiatric condition when it's truly, pain or gastrointestinal problems, and we're not necessarily talking to our primary care doctors. And then the lack of data to evaluate service. So, when we look at studies, we're looking at usually neurotypical individuals and whether this type of treatment works for them. I do find that people with intellectual disabilities, it's such a broad area, right? There are so many different levels and challenges and joys that we get from working with them, but they might come in with very different, even with the same diagnosis, a very different presentation. We do have, and not many mental health providers are aware of this, but there is, kind of what they call the kind of our Bible of diagnosis. It's the DSM-5. And basically, that's a list of every psychiatric diagnosis and all of their symptoms in order to be able to give somebody that diagnosis. Oftentimes, people with intellectual disabilities don't fit well into those categories. So there is a companion manual called the DMID2, which is a wonderful opportunity for training as well as to understand how different psychiatric diagnoses present differently with different levels of intellectual disability. So when I'm training, not only our med students and our residents who come through our practice, not only explaining to them, mental health diagnoses as part of the DSM, but I'm showing them the DMID and say, okay, now, if you're looking at major depression, now let's look at major depression in this book. And how does major depression look? What are the symptoms in somebody with a mild ID, with a moderate ID? How are we going to look at things a little bit differently? And I think being able to understand that companion manual and having that available definitely increases good practice, but it's a big barrier that people don't know that it exists. There's a barrier on the individual level as well. So, one of the barriers for the individual coming in for counseling is that they have limited language skills. So they may have trouble expressing their needs or how to tell others about their distress. They might be able to name different emotions, but not be able to kind of connect those emotions. Or they might not be able to tell you in a sequential timeline what happens so that you can understand triggers. They might have poor or limited coping skills on dealing with anxiety or stress or just the hassles of everyday life. Impulsivity gets in the way of, being able to benefit from or to be able to get the services that they need. They might have challenges in emotional regulation. They have limited social supports. Oftentimes, they have difficulty making friends. And when we're dealing with stress, the first thing we want to do is to reach out for social support. And if they don't have good social supports, that puts them at an increased risk of mental health difficulties. They have difficulty sometimes in problem solving, especially in the social arena, how to work through when somebody's angry at you, how to deal with, differences of opinion. And then alexithymia. Alexithymia is the inability to be able to name emotions and understand the connection of what an emotion feels like in your body. And oftentimes I'm doing a lot of work with individuals to try to understand what they're feeling in their body so that we can use a coping skill in order to help them cope with those difficulties. So, oftentimes somebody will come in and say, well, they just go from 0 to 100. And, the individual can't tell you kind of what's going on because they're not aware of the warning signs that, their stomach's starting to clench up, they're starting to sweat. Their hands are starting to shake. And, what can we do early on in that whole system of regulation to be able to calm down? So oftentimes that leads to some more difficulties. And then transition in and of itself is going to bring its own barriers. There are often long waiting lists for adult care and no support in place. So, you turn a certain age and you're kicked out of your pediatric care without really having anything there to kind of help you carry over until you get to your next level. And that's particularly a difficulty with mental health care. Like I said, there's lack of training for care providers in working with the individuals. And then there can be some problems with healthcare financing and getting insurance. So if an individual, gets to be over 18 and they start getting Medicaid, there are I guess a lot less individuals who will take Medicaid. The rate of reimbursement is one of those big barriers that, many mental health professionals don't want to take Medicaid. So oftentimes I'll hear that, they're getting psychiatric care, but they've got to pay out of pocket. And it becomes just very expensive to get that type of care. And, you would presume with the Affordable Care Act that we would be actually able to get more people to be able to get mental health services because we're extending the time in which individuals can stay on their parents' insurance policies. But we're not seeing that the utilization for young adults is really that much difference with the Affordable Care Act. And oftentimes, our individuals with disabilities are needing to be able to get DDD or SSI services, so they have to move over to Medicaid as their insurance. And that is bringing its own barrier because of the lack of individuals who take their insurance. On the service level, there's a different treatment approach. So whereas, as children and getting mental health services for children, it's usually inclusive of the family, it's very holistic. The family is involved on many levels, and then you move into the adult service realm, and it's focused more on individual patients. And often family members can start to feel left out because they're used to being involved. However, once you reach a certain age with mental health services, there is confidentiality. And so often there's a struggle with, parents or caregivers wanting to know what's going on in therapy and the therapist not being able to disclose what might be discussed. And that can, make people very uncomfortable because they're used to being involved. There's also a change in the perception of the need for mental health treatment. There's some stigma about mental health disorders. And, oftentimes people will think, well, they're just going through, the turbulence of adolescence, and, they don't necessarily need extra mental health care into adulthood. There's a lack of continuity between the pediatric and adult services. So that transition from your pediatric care into the adult care, there's not a lot of discussion about what that transition looks like, or what information is needed to move from the pediatric to the adult care. And then a lack of coordination in making sure that we have that continuity of care across all different levels of specialty, but particularly with mental health. On the individual level, there's a barrier in the transition age. And part of that is that individuals, as they're kind of entering this age, they're at the age of adolescence, they want to do things on their own. They're trying to find their own place in the work world. They have a sense of autonomy and self-determination, and that's something that we want to encourage for them. And they might also start to see the stigma of being in mental health services and say, no, I don't want to go anymore. I'm done. I want to deal with this myself. I can deal with my own problems. So there's this change, which is, pretty natural. And, it's sometimes surprising for family members that these same challenges of adolescence, being autonomous, being able to focus on, social relationships, romantic relationships, kind of the back and forth give and take with parents in terms of control, happen with all of our individuals, right? These are, what we see in neurotypical children and what their challenges are in teenage years, we're going to see in individuals with disabilities, with intellectual disabilities, maybe a little bit later, but we're going to see the same challenges. So, oftentimes families will come for counseling and they're like, oh, they're slamming the door, there's something wrong. Every time I try to help them, they don't want me to help them anymore. And what they're going through is the normal transition of adolescence. And that can create its own barrier because all of a sudden they want to cut the parents out. They want their own independence, but they also might want to say, no, I don't want to talk to anybody anymore. And that can get in the way of continuity of care. So our big problem when we're looking at mental health care is that many people who are dually diagnosed with ID and a mental health problem are misdiagnosed, receiving ill-informed care or sometimes no care at all. An accurate diagnosis is impacted by atypical symptoms. We talked about the DMID2. Many people don't even know that exists, or how to look at mental health symptoms in individuals with ID. There's diagnostic overshadowing, and that's the idea that all challenges, whether they be behavioral or mental health challenges, or due to the person's disability diagnosis. So, for example, an individual comes in and has some pretty significant self-injurious behavior of hitting themselves in the mouth. And they have a severe intellectual disability as well as autism, and live in a group home. And so the self-injury is looked at as part of their developmental disability. However, in talking a little bit more with the staff, I asked them when the last time was that the individual had seen a dentist, and they said, oh, about 3 years ago, he's got a broken tooth in there. Well, that makes me look at the self-injury in a different way, right? This may be a form of communication that the individual is in pain. So diagnostic overshadowing or attributing everything to their disability happens rather frequently, and making sure that we are able to kind of tease out and understand what mental health problems they're having is important. And like I said previously, we've got a diverse population with very diverse needs, and many providers do not feel prepared to be able to treat them. So a little bit on psychotherapy. There are many myths about psychotherapy. One myth is that people with ID are not appropriate for psychotherapy because they have problems with cognitive abilities, that they lack language skills that makes psychotherapy ineffective, that they might be concrete in their thinking, that they can't hold a specific timeline and tell you what happened when. But the reality is that the level of IQ is not a sole indicator for appropriateness for therapy. I actually treat people in all levels of intellectual disability. Some individuals are not able to use words to communicate. Some individuals have idiosyncratic ways of communicating, some stimming type of verbalizations or ways or very idiosyncratic ways of talking about things. So sometimes I need to be able to kind of learn their language to be able to understand what's going on. So sometimes, they talk at kind of like at a third person level, talking about various things that have happened, but not being able to make the connection as to things that have happened to them. And then psychotherapy is effective. And we do know that it's effective. I'll talk about that in a second, but we need to adapt psychotherapy and, making sure that we are giving the appropriate treatment for the appropriate need. Up until the 1990s, most people with ID were treated exclusively by either medication, behavioral modalities such as ABA, or hospitalization. And oftentimes we were basically using medication, and there's a high risk of polypharmacy in this population, to control behavior, kind of as a form of behavioral restraint. And part of that was just not knowing what was going on, not being able to get a good, accurate diagnosis. However, we do know that people with ID can participate and benefit from therapy, and many different types of therapy have been found to be helpful. So that might include mindfulness, it might include dialectical behavior therapy, which focuses a lot on emotion regulation. I love using some of those techniques with my patients because almost everybody's coming in with some emotional regulation difficulty. And we can do this with only some minor adaptations. So definitely, I would not want to discourage somebody from reaching out for mental health treatment because they think that, well, they can't benefit from it because they can't participate in the traditional back and forth talk therapy. There's lots of ways that we can adapt psychotherapy to be able to help, or to use ancillary therapies such as yoga, such as tapping and emotional freedom therapy, such as aromatherapy, movement, music, dance therapy, all of those. One thing that seems to help with being able to work on that challenge, especially in the transition period, is to integrate mental health care into primary care practices. So, many studies have shown that for adults and adolescents who are getting mental health care, it's their primary care physicians or their pediatricians who are going to be the people who are providing the first, at least first line of treatment. So when you look at, treatment for anxiety or depression, you find that most individuals, like over 73%, are receiving medication from their primary care provider, and only 23% are getting it from an actual psychiatrist. Here at the Risen Center, we do have integrated care. So this is something that, I'm very passionate about. Not only does it help to break down the silos and communication among individuals, but we're able to rule out first a medical problem that might be contributing to, problems with emotions or behaviors. So, for example, hypothyroidism can lead to symptoms of depression. Hyperthyroidism or over medication for hypothyroidism can lead to very significant anxiety. Pain syndromes can lead to problems, gastrointestinal pain. Poor sleep can lead to irritability. So being able to rule out all kinds of medical problems are going to be kind of the first line. But having integrated behavioral health within the primary care setting allows for what we call a warm handoff, right? So all of our patients here, one of the things we do is that everybody gets an opportunity to establish primary care, and then they get a check-in with me for a behavioral health evaluation. Now, sometimes people are saying, well, why do I need a behavioral health evaluation? We don't have any problems. Well, the reason we do that is even just to get a baseline, so that if something happens down the road, not only do we have an idea of kind of how they were doing when they were at their best, but also who to call, right? Making that call for the first time, how to reach out to somebody to be able to say, hey, I need some help. If you've never met them before, it's a really hard thing to do. But because we have that opportunity to kind of work within the primary care practice, everybody's already had the opportunity to meet us, and making that call is just so much easier if there's a problem. I want to talk just a little bit about trauma. This population has very high rates of trauma. It comes in many forms. It can be abuse, neglect, abandonment, not being included in social interactions, bullying, as well as medical trauma. It can be cumulative, meaning that it all builds up over time. And for many of our individuals with ID, that's what we're seeing. Or episodic, something that happens, just once. It can change their sense of safety and how they perceive the actions of others, and it impacts their development and mental wellness. And we have some incorrect assumptions. Sometimes people believe that individuals with ID are not affected because they're not understanding these big life stressors. Being nonverbal doesn't mean that they don't understand. And oftentimes we assume that a behavior problem is a result of the developmental disability, kind of like that difficulty with diagnostic overshadowing. What we do know is that there is a very high risk of abuse for children and adults with ID, with regard to not only physical, but sexual abuse. So they're 3 times more likely to be physically assaulted and 2 times more likely than neurotypical peers to be sexually assaulted. They're 2 times more likely to experience emotional neglect, and children with multiple disabilities are at higher risk of abuse and neglect. So we have to be thinking about every individual who comes in through the lens of potential trauma, because the likelihood that they've suffered some sort of trauma is very high. The impact of trauma is that it makes you feel like the world is unpredictable. It increases stress hormones. It can lead to some unexplained physical problems and causes problems in regulating emotions, understanding feelings, and being able to interact with others, which are already problems that our children are having before we kind of add in the trauma as well. Youth with trauma will often show behavioral indicators. So sometimes individuals aren't able to tell us what's happening with them, but we'll see something change in their behavior. So that might be, in terms like trying to go to sleep and wanting to keep the door open, problems with sleep regulation, not wanting to go someplace or refusing to go someplace, which we may interpret as being defiance when it truly is a trauma response. And a trauma response can take one of four pictures. It can either be fight, kind of this fight or flight, you learn about fight or flight responses with adrenaline, but it could also include fighting, flighting, freezing, or fawning, kind of giving in to others as a trauma response. So particularly when we're talking about individuals with ID, we're looking for behavioral changes, a withdrawal from activities that they typically enjoy, problems with sleep, hyperarousal or hypervigilance, similar to what we see in post-traumatic stress for neurotypical individuals. But also on the other side, it can be numbing, emotional numbing, the avoidance of certain situations or people, as well as separation fears. To try to help people recover from trauma, we want to be thinking not so much, what's wrong with you? Why are you acting this way? But what happened to you? So when somebody comes in with a challenging behavior, my first response is to think, okay, what happened to you? Rather than this is something that's your problem. One way of helping with recovery, and I often recommend this to families, is to really work on predictability and routines, kind of follow through on the things that you normally do. It helps to normalize things. Spending extra time with people who you have a trusting relationship with, exploring special talents and interests. Rhythm, movement, music, and art therapies are all very good for not only self-regulation, but coping with emotional or physical trauma. And then the other thing is to always kind of keep an eye out for what is the behavior trying to communicate to me, because there's a reason for a behavior change. And when something like that happens, we have to take a look and take a step back and think, okay, what is this behavior trying to tell me? From the Special Olympics, and I'm the clinical director for the state of New Jersey for the Strong Minds program. They've done a lot of research to kind of see what coping skills individuals with ID are using. And we're finding that of their athletes, 12% report they have no coping strategies at all. And 62% are using avoidance strategies, like I'm just not going to think about it, or I'm going to go to sleep, which actually leads to higher rates of depression. And only 26% are using active coping strategies, actively trying to help themselves self-regulate, actively trying to calm down to help themselves feel better, which is going to lead to increased well-being. So we offer the Strong Minds program at several of the regional events for Special Olympics, just to work on these basic skills. But our individuals, our children are not the only ones who need mental wellness. The caregivers also need to make sure that they're taking care of themselves. Their mental wellness is very important. 80% of parents with children with autism say that they're stretched beyond their limits. So that's a really high level of stress for those parents. And we know that that people who have children with ID are worried about their long-term outcomes, their social acceptance, how they're fitting in with others, and the limited social supports that they're able to receive from other parents. And individuals, parents with disabilities or children with disabilities have a high rate of emotional distress, higher rates of depression and anger than children without disabilities. One thing we do offer here at the Risen Center is we provide not only caregiver support to help for the stress that caregivers are undergoing, but we also provide the ability for family members to get their primary care here too. Sometimes mom or dad haven't been to see their doctor because they've been so focused on helping their children. So all together, I mean, I hate to kind of paint such a difficult picture of mental health, but we do know that we have children who have a higher vulnerability to mental health problems. So how do we counteract this? what I want to talk a little bit about are some specific strategies to foster resilience. So resilience is the ability to adapt to stress, to trauma, to adversity, and everybody needs emotional resilience. This is kind of your bounce back, how you're able to kind of get over something, and it typically includes having a good temperament, having good social supports, and being able to advocate for yourself. So the CDC indicates some positive mental health indicators, and they include having affection, resilience, curiosity, persistence, self-control. And we encourage resilience by having secure attachments, good emotional regulation, like we talked about before, and good interpersonal skills. And all of these things can be taught. They can be taught in counseling, they can be taught by direct support professionals, they can be taught by parents. So all of these things, we can make a huge impact through resilience training and working on resilience with our loved ones. To work on resilience, we have to look at the difference between enabling and empowering. So when we're talking about enabling, and this is always coming from the very best, best heart, best wanting to do the most for your child, but it's the practice of over helping. It's using the disability as an excuse, both from the caregiver and the individual, doing things for the individual rather than letting them do it themselves, and making excuses or blaming yourself, blaming others for the challenges that the individual is having. So some ways that you can combat enabling, is to think about, how is your parenting approach helping them move forward to be independent? Are you giving them enough opportunities to learn from their mistakes and build coping skills? And quite honestly, we don't learn unless we have adversity, and being able to kind of overcome adversity is probably the number one way of increasing somebody's self-esteem. Being able to say, hey, I can do this on my own, or I can do this with some support, but I don't need somebody to do it for me. Am I trusting others to help my child find support and resources? And am I spending any time focusing on my own needs, right? So sometimes we give up everything for our children, and we are not necessarily teaching them or modeling good skills of self-care. So being able to care for yourself is actually going to help build resilience. Empowering is the opposite of enabling. That's allowing the individual to express their feelings without being judged, being supportive while trying not to be criticizing or nagging, so we can encourage them to make their own decisions, allowing them to own their successes and failures by letting them do things for themselves, and allowing them to make choices. And even when somebody has a guardian, if they have guardianship status over their loved one, being able to give them a voice in making decisions is going to be very important for self-esteem, for independence building. But also what we find, I talked a little bit about trauma and about the high incidence of abuse. We find, and there's been some research to also support this, that the more often we give people the ability to make decisions in their life, the less likely they are to be abused in the future. So being able to give them that gift of making those decisions is actually going to help them in the long run. You can also help by redirecting. So let's say your child, who is often coming to you to be the fixer, comes to you and wants to know, I need help. What can you do? What I'm going to encourage you to do is to redirect them. So first ask them if it's an emergency, when they call in a panic. And you should have kind of talked about this a little bit previously, because we're talking about transition, and people are, your loved one, your kid is moving out from the school world into the working world, or sometimes perhaps living on their own. So knowing what's an emergency and what's not, and then ask them whether they need help or they just need you to listen. Redirect them to the person who can help them, that isn't you. so that they can begin to utilize supports in the community, and remind them of times in which they've been able to overcome adversity. What strategies worked from them before? What kind of coping skills can they use right now to help calm down so that they can get to better problem solving? Because when we're very emotional, we're not really thinking. Two totally different parts of the brain. So we want to be able to calm down and emotionally regulate so that they're able to really effectively problem solve. And this can mean, as a parent, you need to shift your approach. Before you offer suggestions, you need to think about what has happened, what can they do, and what coping skills can they use. And it may also mean some flexibility in thinking about what the timeline looks like. Remembering that success is different for every individual. Everybody's on their own timeline. We shouldn't try to compare our children with other children and where they are in their independence and in their life trajectory. Understand that every step forward is a step in the right direction, and help create a mantra, something that they can say over to themselves, that they can remember that they can do what they need to do, and that they can be self-sufficient and capable. So your opportunity is to teach self-advocacy, being able to stand up for themselves. And, sometimes this might mean even when you go to the doctor, right? Giving them the ability to be able to tell the doctor what medications they take and why, what their allergies are, writing down in advance what questions they might want to ask, giving them the opportunity to build their self-help skills, by giving them the freedom to try things on their own, but being there to kind of catch them if they need some help, teaching them accountability and encouraging relationships, cultivating self-esteem as well. Supported decision-making as an alternative to guardianship for individuals where this is appropriate is also very helpful and a great opportunity to encourage not only advocacy, but also resilience. So I want to give you some resources, and I think we're going to pop these in the chat so that you'll be able to click on them. These are just some websites and some videos that you can watch on building resilience. There's a good video on naming emotions. And I also included a trauma toolkit for children with ID who have experienced trauma, so that you could have those resources as well. There's also this book called Mental Wellness in Adults with Down Syndrome. It's a free download, which is really awesome. And it's on the Down Syndrome Advocacy Center in their resources. I love it because it talks about preventing mental illness, yearly assessments, structures and routines, how to deal with emotional and behavioral challenges. And I find that it's helpful for even individuals who don't have Down syndrome. I think there's just a wealth of information there. And when you go on their website, they have tons of resources on just about everything. They have social stories, they have videos. So I'll give you an example. I had a patient come in who recently choked because they were eating too fast. And I was able to provide them with not only a social story for how to slow down eating, but they had a video as well. They have a great occupational therapist there, that I could then provide as a guideline for how to slow down eating. And you'll find that there's a ton of these available on the website too that you might find helpful. Special Olympics, as part of their Strong Minds program, has a lot of resources as well. One of the things is healthy sleep tips. I find that good sleep and being able to address sleep problems is probably the first thing I do with a lot of individuals, because getting a good night's sleep is so important to irritability and anxiety and all of those kind of things. So these are all different guides that are free for downloads. If you haven't seen it before, there's the Enhanced Family Support Crisis Handbook, which is wonderful. It's free download. It is for the state of New Jersey and really kind of gives all information related to crises. Who do you call? When do you call? What is a crisis? What isn't a behavioral crisis? Who all the people are that you might meet if you do have to go to the hospital. And then this wrap booklet, I think there's a small fee for it, but it really is a great way of developing a plan that kind of wraps around the individual with mental health difficulties for coping skills, who they can call for support when they need it, really kind of focusing on that resilience building as well. So thank you very much for having me here today. I appreciate the time and I really appreciate the invitation. I'm not available right at this moment for questions. However, I do have my email address here. So if you have any questions or you'd like a little bit more information, you can feel free to reach out to me.